Good evening, ladies and gentlemen. Welcome to the Peter Darwin Institute for Infection Immunity. On behalf of the Convergence Science Network partners, it's my pleasure to welcome you here this evening to our first event for 2016. My name's Luan Ismail. I'm the Executive Director of the Convergence Science Network. The past few months have been an exciting time in convergence science. There's been widespread discussion about the ethics of gene editing, with scientists at the Francis Crick Institute in the United Kingdom having recently been given approval to genetically modify human embryos. Stem cells have been used by US researchers to model Alzheimer's disease, and human pluripotent stem cells have been used to grow kidneys in a dish. And last week in Melbourne, you may have heard the news of a device that's been developed by a team of multidisciplinary researchers at the University of Melbourne that would enable paraplegics and quadriplegics to power an exoskeleton with their thoughts. The goal of the Convergence Science Network is to share the stories of how collaboration among the life, physical and engineering sciences is contributing to knowledge that seeks to improve the health and well-being of people here and around the world. And we achieve this by enabling the public an opportunity to hear from those who are doing the research, making the breakthroughs and developing the technology that delivers on the promise of better health. And I think this evening's event will certainly deliver that. I'd now like to invite your host for the remainder of the evening, Dr. Megan Robertson, from the Director of Research at St Vincent's Hospital. Thank you, Megan.
Thank you, Luan. Welcome, ladies and gentlemen. And thank you very much, Luan, for organising this fantastic event this evening. You are the lucky few who've made it into the room. There are over 260 people registered for this event, and there's a waiting list. And I think that shows how exciting convergence science is and how much interest there is in the general community and in all of us interested in science and health in the fascinating interplay of collaboration in convergence science. Now, tonight we're going to hear a local story of collaboration, a great idea, collaboration, and then moving it right through to translation and clinical impact to a device or a story that is actually changing the lives of people in Australia and has the potential to change the lives of people worldwide. Now, to introduce the speakers, our first speaker this evening is Professor Peter Lee. He's the Deputy Head of the Department of Mechanical Engineering at the University of Melbourne. Peter is widely recognised for his work and has a particular interest in orthopaedic and injury biomechanics and the mechanical properties of biological materials such as cartilage, muscle and bones. Peter will be followed by Dr. David Ackland, who is a Senior Lecturer in the Department of Mechanical Engineering, also at the University of Melbourne. And Dr. Ackland's research has focused primarily on joint structure and function through computational modelling and experimentation in human movement, with a major focus on the upper limb and jaw joint behaviour and joint replacement surgery, areas that are very topical and obviously very prominent in healthcare. Our final speaker is the clinician from St Vincent's, Dr. George Dimitrov. He's a senior maxillofacial surgeon at St Vincent's Hospital, Melbourne, an honorary fellow at the Melbourne Dental School at the University of Melbourne, and the founder and director of OMX Solutions, a Melbourne-based startup company which specialises in the development of new and innovative 3D jaw components. So as I said, we'll run through the speakers, we'll run through consecutively, and at the end of this, the three presentations, I'll invite them up to the stage and get you to ask your questions. So first of all, please welcome Professor Peter Lee.
Right, thank you, Megan, for the warm introduction, and welcome to the University of Melbourne. Now, we as a team are really honoured to be able to give this presentation. We will be giving a three-part presentation, as Megan has already explained. Now, I'm going to just tell you what it entails. It's got something to do with a bridge, yes, a railway bridge, right? A jaw, and of course, not forgetting, why we are here 3D printing. Now, so before I do that, I'd like to show you a picture, I think which by now most of you are sort of quite familiar with. Now, if you look at this picture, immediately you can see from the X-ray, right, that there is something in there that doesn't quite, maybe we can describe not quite human, right? Okay, so this is a 32-year-old person, was born with a missing jaw. You can imagine, having a missing jaw. When you chew, it'll be, uncomfortable. Your face will be lopsided. Now, so in order to fix this, surgeons, they can implant what they call an artificial temporal mandibular joint, or TMJ, right, for short. Now, so that TMJ, maybe I'll just show it, as that's this one here. All right. Now, so what is so special about this TMJ prosthesis that you see here? Now, so I promise that we will come back to this slide. I also promise you a bridge. Now, so here it is. This is the famous, fourth rail bridge in Scotland. A wonderful piece of engineering. I actually spent quite a number of years living in Scotland. So if you go to Edinburgh, Glasgow, you probably, pass by this particular bridge. Now, I'm a bio, but also a mechanical engineer. So bridge like this do fascinate me quite a bit. Now, so it's sort of a cantilever bridge over the Firth of Forth. It's a bit of tongue twister. 2.4 kilometers long, completed in 1890. All right, that's pretty long ago. But the bridge was actually, what is really interesting is the bridge was actually the first major structure in Britain that is made out of steel. All right, so one of the key reasons, right, we all know that the Forth Rail Bridge is still standing there, is the engineers actually spent a lot of time trying to understand what the material properties of steel is. Right? They know exactly how much load, a material like steel can actually take. Now, for that matter, the seats that you are sitting on, the plastic, the metal bits and the fabric, whoever designed it, right, have an understanding of, how heavy a typical human weighs, right? Or else, we'll all be falling onto the floor. Now, so imagine, right, trying to build something to replace your bone. Right, we cannot actually do that if we do not have a clear idea of what the material properties of bone is. Right? So that's really fundamental. Now, biomechanics is what we do. Right? So this, in University of Melbourne, we have a nice biomechanics team, and you can simply define biomechanics as the study of structure and function of biological systems. Just like in any engineering project, before we can actually build or replace any human parts, we need a clear picture of the properties of behavior of human tissue. So materials is the first perimeter or first challenge, right? We need not just the synthetic materials that we put into the body, but more importantly, the biological tissue or that are already in existence in our body. Now, next is geometry. Now, shape is also a major challenge, when dealing with the human body. Now, if you ever wonder why the bones in your hands, and your feet, are shaped like that or sort of connected like that, I mean, they are really complex, right? But it is shaped like that, because it allows us to do fancy stuff, like me wriggling my hands. Now, if your hands and feet are originally designed by an engineer, it would probably be like either circle or square in shape, right? That's how engineer thinks. All right? Now, so in biomechanics, we have to learn to design in a way which complements the complex shape that are already in existence in our human body. But more importantly, we have to learn to design in a way that helps restore function, the original function. That's what we are aiming for. Now, I also have loading there. That is the third major challenge. Now, to get all of us to appreciate what I really mean by loading, I'd like to show you this slide. All right, this is not me and this is not my holiday picture. Right, but I'd like you to imagine that you are this person. Right, I know skiing downhill, at very high speed. what happened is the load transferred from the ground onto your ski, and then to your ski boots, and then onto your knees, right, require muscles to react, right? In order to stabilize you. If your muscles are not reacting, you just fall over, right? So muscles around the knee are really working really hard to stabilize you. In fact, not just the muscles around the knee, but actually the muscles around the whole body, almost the whole body is doing the job. Now, very often we don't even realize that, our muscles are so active in doing something like this, because all we care is, the adrenaline, and then, looking and make sure we don't hit somebody or fall over. But we will find out, the next day when you wake up, your body is just aching all over, right? We have that experience. So muscles are really working very hard. Now, so in biomechanics, we have to understand how load is transferred to our joints, and how load, can basically, for that matter, or loading that is acting on the implants that we put into our body, right? All these loads need to be fully understood and even calculated, so as to make sure that nothing breaks. Now, so if I want to, put it in a nutshell, without the loading knowledge, it's like building a railway bridge without actually knowing how heavy the train weighs. Right? I don't think any engineers would do that. So in summary, right, 3 very important parameters or challenges in biomechanics: materials, geometry, and loading. Right? So just bear in mind these 3 parameters. Now I'm going to switch gear very quickly, okay, and then talk about 3D printers. All right? Now, so in recent years, surgeons, engineers, we've all been really excited, right, about the potential of 3D printers. Now, have you ever wondered why? Okay, so I'm just going to try and connect, to what I've been talking so far. Now, 3D printers are really excellent tools for building very complex shapes, right? Now, they're also very good tools for building things using different materials. Now, so the keywords here I want to emphasize is geometry, shapes, and materials. Now you can start to appreciate, we have quite, an interesting tool. Now, so there are this 3D printer is sort of becoming an ideal instrument that could help us, contribute to 2 of the 3 major challenges, that I've been talking about. You can actually build all sorts of shapes with a 3D printer. You can build, big bones, small bones, or even funny bones. There's practically no limit. All right, in terms of geometry. Now, as for 3D printing materials, right, it's also accelerating. I mean, the research in this area is just tremendous. It's accelerating really quickly. Now, so traditionally, we all know that, we use plastic or polymers, right? It's easy to handle, low melting point, the whole process of melting plastic and then, fusing them together. But now you can print metals. You can print titanium, you can print stainless steel. And on the other extreme, you may even have read it, you can actually print biological cells, right? These are living organism cells. But that's a story for another day, right? Okay, now, so I think most of you are already familiar with 3D printing. So just to recap, it is sort of a layer by layer manufacturing technique. Sometimes, we refer it as sort of an addition process instead of, taking material where you're adding material on top. Now, the machine really deposits 1 layer of materials on top of another, and then, repeating this process, eventually building a 3D object. I think the simplest way to explain, sometimes I tell my students, is that, it's like squeezing toothpaste, right? If you squeeze toothpaste on top of another, you can build quite a nice art piece, okay? Right, some of the kids may have done that, Now, so today you can actually buy a very good 3D printer, like this one here, for less than $1,000. You can build all sorts of stuff, Christmas present and so forth, all right? But what about metal printers? Okay, they're starting to gain popularity. Metal printers don't look like that. They look like this, like a washing machine and a refrigerator, Right, so they are pretty huge, very big, and very expensive. They're still in the range of hundreds of thousands of dollars, right? Now, but the principles are quite similar. You still start with a 3D, computer model, and then the metal printer then spread metal powder, right, on the tray. And the print head now, comes in, and sometimes the print head, can be a binder material that's squeezed out of the print head, but often it's also a high-powered laser. It moves and fills all the powder to the exact location, of the model that you're trying to build. So the machine then spreads another thin layer on top, and then, you have the print head coming again. So it's sort of built, from what we call a bottom-up process. Now, so because, the whole process, being able to print in metal has actually changed the game quite significantly. Because, in the past, you are printing objects for visualization, but now you can actually print objects that you put into service. So it's no more a rapid prototyping, it's actually a rapid manufacturing process now. Of course, when you say rapid, it is still slow. When you talk about medical industry, I think there's no doubt that 3D printer will change the medical industry. Like for example, we are already starting to talk about like on-the-spot implants. Is this actually science fiction, or is it maybe it's not too far away? I've mentioned about the challenges in biomechanics, geometry, materials, loading conditions. Now you take this and then you move it to 3D printing, and then you start to see that there are still quite a bit of challenges. So hopefully by now you can appreciate the various challenges in biomechanics. Now, so unlike a railway structure, we know that bones, your bones, my bones, they're changing. Right, bones are living materials. It even repairs itself. You put a screw in it, and then it will start to react to it. Now, your ligaments and tendons, my ligaments and tendons, are subjected to forces that can be so different. Now, take for example chewing. Right, if you chew on freshly, made tofu, versus chewing on, overnight meat, right? That's a big difference. All right. I don't recommend that, chewing on overnight meat. Okay, now the good news is that, for the past 50 years, biomechanical engineers has actually done a significant amount of work trying to understand, your properties of tissue, how they react to mechanical forces. We have developed accurate computation models, right, which you will see here, that could predict loadings in the body. Now, so knowing how a tissue behaves, how it reacts to different mechanical loading, has enabled us to do wonderful things that has improved our quality of life, right? Even make us live longer. So back to this question, right? What is so special about this TMJ prosthesis you see here? So the story actually begins one afternoon about 3 years ago. We have a surgeon, George. Out of the blue, he came to our office with a very interesting sketch on a TMJ, prosthesis that he's designed. On sort of paper, not toilet paper. I think he has a higher class than that. He's got good paper. Right, and then his question to us was very simple. He says, will this actually work? Right, of course we don't know. So, as engineer, our heads start clicking. Oh, materials, geometry, loading, right? So on that note, I will step aside. I will let David, tell you the rest of the story. Right. Thank you very much.
Well, I thought I'd start from the beginning, which was 3 years ago when I first met Dr. George Dimitrov. And he came to see us and ask us if we'd like to be involved in the development of an entirely new prosthetic joint replacement system for the human jaw. Well, the human jaw, or the temporomandibular joint, is the articulation between the condyles of our mandible, so the tips of our mandible, the upper tips, and the skull. And in cases of severe end-stage osteoarthritis, or trauma, or congenital abnormalities, a total joint replacement can be used to restore function and reduce pain. A total joint replacement is a prosthetic or artificial component that can replace a bone. In the case of temporomandibular joint replacement, or TMJ, joint prosthesis, we have a component that replaces the articulation between the jaw and the skull. So George came to us and he presented this problem. And the problem is that there's only one supplier of prosthetic joint replacements of the human jaw in Australia. And they supply 3 sizes, a small, medium, a large. And this is one of the components here. This is the Biomechanics microfixation device. And it simply doesn't fit the whole gamut of different geometries and complex anatomy and configuration that you get, that one would see clinically. There are a number of other issues with it as well. It doesn't really conform well to the anatomy of the jaw or the mandibular ramus. And there's a nerve, this mandibular nerve here, which runs underneath the implant. And it's actually quite easy for the surgeon to place screws through the location of the nerve and to actually contact the nerve. And if that's the case, the patient can lose sensation to their face for the rest of their lives. So there's clearly a problem that needs to be solved. And George came to us and asked us if we could be involved in helping him solve this problem. So, of course, we were very, very keen to be involved, but we never worked in the area of maxillofacial surgery or biomechanics before, so it was all new to us. But we looked at our tools, and we have expertise in musculoskeletal modelling, developing dynamic models of bones, muscles, tendon and joints. We perform experiments on human subjects to understand human movement and loading at joints. And we also perform cadaveric simulations. And these are where these sorts of simulations involve applying loading to cadavers to see how implants respond, or even the effect of surgery on the way joints behave. So we thought that probably a good place to start would be to develop a musculoskeletal model of the human jaw. And by developing a musculoskeletal model of the jaw, we would be able to develop an appropriate anatomical joint replacement for the temporomandibular joint. So from George's problem definition, we decided we'd develop a musculoskeletal model. And from this model, and based on the anatomy of this general model, we could then come up with a design. And we could use this model to evaluate the effect or the functional performance of the implant under physiological loading. So we could make this model bite and chew, and we could quantify the effect of the loading on the implant performance. And this would help us to iterate the design, improve it until we're happy. And then we could do some cadaveric testing. We could place the implant in the cadaver. And if all is well, then perhaps the first prosthesis recipient would be potentially worthy of our device. So I thought I'd start with how we develop models. It's done often using image analysis. I know it's a slight digression, but we're working very closely with Melbourne Museum in developing computer models of the blue-ringed octopus. It's one of the most deadly marine creatures in our waters, and it has a number of very interesting components internal, these anatomical structures, such as ink sac. It's got its own jaw, and it has a gland that secretes this tetrodotoxin. And to give you an idea of how deadly it is, the curator, Julian Finn, who obtained this specimen, had the specimen in a vial with water when he was out diving, and splashed a little bit of water from the vial on his hand, and his hand went completely numb. So it's incredible how deadly that tetrodotoxin is. But what we can do is we can actually perform an analysis, an image analysis, by taking images through stacks, slices through the organism, and we can reconstruct them to produce a 3D geometry, and that's called segmentation. And we did that, and for the first time we were able to see incredible anatomical structures. The esophagus runs through the middle of the brain of this creature, so the brain is a donut. And of course we see incredible jaw features. The jaw is like a beak of a bird, which is actuated by muscles with no bone whatsoever. So we use these sorts of techniques to come up with a model of the human jaw. And we used this data set called the visible human male data set. I'm not sure if you know of this data set, but it's one of the most widely accessed data sets to biomechanical engineers. There was a young man in the United States who was sentenced to execution by lethal injection for very violent burglary and murder. but he decided to donate his body to science. And he was subsequently executed, and after the execution, his body was frozen in a gelatin water solution and sliced, millimetre slices, all the way through his body. So each millimetre was an axial slice. And those slices were photographed in high resolution and made available to people like us. And what we can do is we can access those slices and trace around the individual components, such as the bony anatomy in each slice, digitally trace around it, and then superimpose all those traces, slice by slice, to produce a 3D structure. And that's exactly what we did to produce the anatomy of the skull and the jaw. Not only did we get the bone, we got the cartilage and we got the disc and we got all the muscles. So we got quite a lot of detail out of this. So we used that generalised geometry of the visible human male to develop our first model. And here it is. We've got all the major chewing muscles. They're the most important load creating muscles of the jaw, and in our model those muscles essentially shorten and create force vectors, and you can see these force vectors, they're like arrows there, and this is the resultant 3D model that came from quite a bit of work, actually initially started by an undergraduate student, a very bright undergraduate student. So we developed this musculoskeletal model so that we could simulate the loading conditions on the implant and size up the implant and come up with a good implant design. And George, I hope I'm not stealing your thunder here, but this is one of the first sketches of the TMJ design, similar to the one I believe George came up with at the kitchen table one breakfast morning with his kids. But you can see the condylar component here, which is screwed to the mandible, and this fossa component, which is screwed to the skull here. So that was what we started with, and of course we had to convert that into a 3D geometry and ultimately a product. So we used some of our engineering software, SolidWorks, to come up with this specialised prosthetic temporomandibular joint design. And we've got a nice, we're just going to have to reach around the corner here. We've got this contour here, this curvature, which fits the anatomy of the jaw. We've got sort of these flanges here on the side of the fossa to avoid dislocation. And this implant, of course, avoids contact to the nerve, which might occur intraoperatively with screw placement. So it's a vastly improved design to the current state of the art. So this was the design that was developed in the School of Engineering, and here is the resulting musculoskeletal model simulation that we created. So we performed a simulation of chewing, and we were able to predict the loading incurred by the muscles and therefore the implant. And you can see the masseter, the temporalis, so the major chewing muscles there, and we've got a chewing motion, and there's the implant. You can see the implant is under load there. It's a bit like a ball and socket, the temporomandibular joint there, but it does translate. So there's a fair degree of translation and movement there, which attributes to a different sort of a load distribution. But we've got these tools that allow us to interrogate various parts on the implant and to assess and evaluate the stresses. And this is really critical because we need to understand, we need to know that the implant is going to be able to withstand physiological loading when this goes into a patient. So we could actually simulate what's called a bite force. So when we chew and we bite down on food, we can produce around about 200 newtons or 20 kilograms of force. And if we maximally contract our masticatory muscles and bite down as hard as we can produce upwards to around 100 kilograms of bite force. So we're actually able to use these sorts of boundary conditions along with all the muscle forces to simulate the worst case scenario, which is a maximum bite. And we're able to get all this very interesting engineering data, which I won't go into too much detail, other than to say that we got cartilage stress. So on the other side, there's a normal joint and there's cartilage at the joint. And the cartilage stress is actually very low, only around 2 megapascals. It's actually about 40 or 50 times lower than the stress loading at the knee joint. And it's interesting to note that we see a lot fewer incidents of osteoarthritis at the jaw than we do at the knee. So it's a quite low loading joints, the temporomandibular joints, but nonetheless incredibly important that we know the loading and that our implant's going to be okay. Another very, very interesting thing we found was that when we had this implant placed, we had screws in here. The screws aren't in this picture here, but we found out that the upper screw actually has a lot of load transmitted to it. Turns out that that's one of the most difficult to place screws intraoperatively because the surgeon is working through an incision, a submandibular incision, and has to go in at quite an oblique angle. So we found out that there's a lot of load passing through that, so it's actually critical that the surgeon places that screw. So we got a lot of interesting and unique data from these simulations. And of course we found that there was no way under a maximum loading bite that this implant was going to yield or buckle or crack or fracture or anything like that. So we had quite a bit more confidence. Now, I was not sure whether to show this or not, but cadaveric testing is so important in biomechanics, I thought that I really do need to show this. Now, this is actually the first trial surgery. So the prosthesis was printed in plastic and it was implanted in a cadaver. Now, the implant was placed during a simulated surgery, but the nice thing about cadaveric testing is that we can actually remove a lot of the musculature and soft tissue. So we've reflected the masseter, the big muscle, and you can get really, really great exposure, which you could never get on a patient. So we were able to place the implant and move the implant with all the force we could to see how it behaves. And thankfully with these nice flanges here, the implant didn't dislocate. And so we had very, very good range of motion and good functional performance of the implant. So this gave us a lot of confidence going into the surgery, potentially with the first patient. And here is the first patient, a young man, a very charismatic man, Richard Stratton, who presented with the condition condylar aplasia. So as Peter mentioned, he's actually missing his right temporomandibular joint. So the condyle is just simply not there. So you can see he's got a slightly droopy or lopsided jaw. Now what was done for Richard was that the implant that we had developed together was actually altered, it was changed to match his anatomy. Now this is one of the great things about surgical planning with 3D printing. We could actually scan Richard's head and 3D print Richard's skull. And we could 3D print the prosthesis, and there's the prosthesis right here, the brand new prosthesis, and we could actually match them up. So in a consultation, when Richard visits George, George can have the patient's skull there and can have the implant that's going to go into the patient and see that it's actually going to be a perfect match to his anatomy. So really amazing possibilities for surgical planning there. So after a bit of sizing up, the implant was ready to go into Richard, and George, in a very successful first surgery of this entirely new prosthetic joint replacement, printed in grade 5 titanium, biologically compatible, and high density polyethylene. It went into Richard in a surgical procedure that lasted a few hours, and we had very, very positive outcomes almost immediately. So in the months after the surgery, you can actually see, if we just draw a line parallel to the eyes, that that George has actually completely straightened the mandible. So there's quite significant symmetry there. But also, Richard no longer has chronic pain of the jaw. Often he would have pain flaring up when under stress, for example, and also vastly increased range of motion of the jaw. Now here's the side-on perspective. Now he did request that he have a Brad Pitt jawline, but he was actually given his own natural jawline and a prominent chin, which you can see there. And apparently he didn't really appreciate that he didn't have a chin until he saw the post-operative picture there. So he's very, very happy and absolutely delighted with the result. So we can say that this procedure, this prosthetic total joint replacement of the temporomandibular joint has occurred, I think, around 12 times. So there have been 12 individual cases of recipients of this prosthesis, and it's really a great success story of a really strong and close collaboration between engineers and clinicians and a lot of other people that supported this work. So there's a lot to glean and to gain from this process, this collaboration and this working together, and a lot of possibility with 3D printing in the future. So I'm going to hand it over to Dr. George Dimitrov, oral and maxillofacial surgeon and director and founder of OMX Solutions. Thank
you. Thank you very much, David, and thank you to the people who invited me along to present tonight. I thought the best way to present anything that is not directly to my own colleagues, my own surgical colleagues, and to the general public, is to tell a story that really people can connect to. When I did Richard last year, there was a lot of media attention, only because it really changed this gentleman's life. And I thought to myself that if we're going to really get a move on in the 3D printing world, then I really have to take that big step and set up my own company to accelerate the ideas that have come to my head. And what you'll see in my presentation is I've gone beyond the temporomandibular joint. When I thought about setting up this company, OMX Solutions, I thought the whole idea is to develop innovative medical devices that surgeons did not know they needed and that would become essential in their everyday practices once they see how it actually functions. Innovation is basically powered by problems and challenges that require solutions. And so let's begin with the first challenge. This is Alexandra. Alexandra is a 20-year-old nursing student at ACU. And what you see there is not a young girl that's smiling. The fact that she's showing that much teeth doesn't mean that she's a happy girl. And when you look at the X-ray, you see, and I see at least quite clearly, that the jaw joints here are dissolving away. And as the jaw joints dissolve away, this chin is getting further and further back. The problem with Alexandra is that if you try and do the osteotomies, what we call bone cuts, to try and rebuild her face, the sad thing is that she has unstable joints that will continue to dissolve. And then it leaves us with the embarrassing situation of further surgery. So I thought long and hard about Alexandra's case and thought, what could we do to stabilise the jaw? What could we do to stop those dissolving joints? So we decided to get together with the engineers, get a 3D model of the skull, and then see if we can apply the same technology we had for Richard to Alexandra's case. And as you can see, the purple is basically the same design as Richard's, and of course the fossa component. So what we do is we get rid of the dissolving component and build a prosthesis that's custom made, not only to provide a brand new prosthesis to replace a diseased jaw, but also to help move forward the actual lower jaw. So in one operation, what we're doing is we're not only curing the problem of a dissolving jaw joint, but we're also correcting her lower facial aesthetics and her awkward bite. So as you can see here, we've got the 3D printed nylon skull, we've got the 3D printed jaw, which we call the condyle, and then we've got the plastic fossa. The reason we need a plastic fossa is because if you have metal against the base of skull, eventually the metal will erode into the brain. So that's why it's important to have the plastic match to the metal. And so the next step is to undertake the surgery. Now, you're not seeing double there. What you're seeing is two joints side by side. Of course, we had to also correct her mid-face and a few other things. That's the metal plates that are there. But just to give you a better idea, you can see the two joints end on, okay? Sitting in the base of the skull quite nicely. Why? Because we were able to match it on the skull. And I knew exactly where to place the joints. And 3D printing took away that guesswork. This is how we started, and this is how we finished. Alexandra is now a normal girl, just about to finish her registered nursing training. And she doesn't get the stares and looks that she used to. So she went from something that people stared at to just another person in the crowd. And that's exactly what we aim to do. The second challenge was Michelle. Michelle is a 69-year-old lady. And the story went like this. Michelle saw on TV Richard Stratton's case. And she came to me with a very common problem. Can you use the same technology you used for Richard to solve my problem? So what was Michelle's problem? There she is, and there's her profile. You're probably saying there's nothing wrong with that. It's a typical 69-year-old lady. But when you take the X-ray, what do you see? You see hardly any bone here and hardly any bone there. So she did the rounds, and dentist after dentist would say to her, oral surgeon after oral surgeon would say to her, sorry, you do not have enough bone for conventional implants. The issue was she was wearing false teeth, which were unstable. So if you can imagine at her time in life where she found it very difficult to chew and difficult to talk because the dentures are unstable and there was nothing that dentistry could offer her without undergoing complex reconstructive bone grafting, etc. And so I thought long and hard about Michelle, thinking, how can I use the current technology that we've got? Eventually we came up with this idea. Now you're probably thinking, what on earth is that? Well, let me put it into a context. This is what it is. It's called a subperiosteal implant. So on a 3D model, what's happened is that we've basically covered the anterior part of the upper jaw, and we've made some perforations, and these little things are called abutments. Now you're probably thinking to yourself, well, what exactly is this structure? Let's move along. As you can see, the design that went into it, and the important thing was with 3D technology, that we not only made a base plate to support these structures, but we also had to make sure the direction of these structures was such that you could fit teeth on them. Okay, so it's very important that when we built the substructure that we could apply directly to the bone, that we could build teeth on them, so that we went from this to this. So what do you see? In her pre-op photo, you see she's got hardly any bone. And in an operation that lasted about 50 minutes, we were able to place two substructures. Very simple surgery. She was out the same day. Okay, so what are these little bits? The teeth. What's so interesting about this picture? What makes it really special? She's still asleep. We have just finished the surgery and we've popped on the teeth. And we not only have clipped it on, we have screwed it on. So this lady went from no teeth to full fixed dentures. And do you know what that means? that means that for the first time in 40 years, that's how long she's been missing her teeth, in 40 years, she's woken up and she can actually chew and speak and just live a normal life. So ladies and gentlemen, the subperiosteal implant, the technology we use to develop this, is going to be a major breakthrough in dentistry once we've released it. At the moment, we're going through so much paperwork to make sure that the TGA is going to be happy with it, that it is incredible how much work does go into these sort of things. But I think that once we're ready to release it, it will change the face of dentistry forever. Which brings us to our final challenge, which is the big challenge that we're facing at the moment. This is Patricia. Patricia's 31, going on 60. You cannot believe she's 31. She's been through so much. Poor old Patricia is from Sydney. Once again, she contacted me through my practice saying, we saw you on television. Can you use that technology, same old story, to sort me out? So what was Patricia's story? She had a lip cancer that was burnt multiple times. Eventually, when they finally got the biopsy, it was a cancer, but by that stage it had spread, not only to her whole lower lip, but it had spread to her jaw. And so she had her jaw lopped off. And sadly, the best surgeons can offer her is a fibula graft. A fibula graft is basically the minor leg bone. Now think of the leg bone as a straight bone, and think of that reconstruction as the best we have got to this day. So in oral maxillofacial surgery practice, whenever I travel around the world, they talk about the wonders of the fibula graft, the leg bone, to reconstruct a jaw. Now, no one has actually told me how a fibula is supposed to replicate the complexities of a jaw. But it's the best we've got so far. So her question is, can you use the technology that you have to rebuild me a new life? And we thought about it for a while. And we thought, yes, we could. We certainly can build a new jaw. And when you look at it closer, what do you see about this jaw? It's 3D printed, and these little discs here are where we are going to place the teeth. So when you look back on this design, you think to yourself, now why didn't I think of that? Because when you look at reconstructive surgery of the jaws, no one out there has ever thought of the idea of connecting the teeth to the jaw. They think the teeth is something totally separate, whereas it should be part of the reconstructive phase. So this is our first prototype. This is the same lady, 3D printed jaw. And what do you see here? These are the different connectors that we're trialling. And on top of that, we're actually going to give her teeth. And what does that mean? That means that she'll be able to return to normal speech. She'll be able to chew again, and she'll be able to look normal because of the contour. See, we've even built a chin for her. And all those little holes you see there is where we're going to connect all the muscles and the ligaments when we finally do the surgery in the next few months. So really, OMX Solutions and the university, there is a partnership. And successful commercialisation relies on proper validation. We're there to develop new ideas. The university is there to tell us whether it's possible. OMX is a local company, but we do have global aspirations. We hope to grow very quickly over the next 12 months. It's a matter of where we get funding and support. The University of Melbourne is right behind us, and we would benefit from any other interested parties as well. So, ladies and gentlemen, to conclude, the future belongs to those who can best exploit digital tools. This young child may one day be the beneficiary of soft tissue printing. So I'll leave you with that, and hopefully I'll be able to answer some of the questions you may have. Thank you.
Thank you very much to our speakers. We'll open it up for questions.
Osteonecrosis of the jaw is probably the worst situation I've ever seen, and people are just dying in front of you. I imagine with the technique you have now, you could approach this problem.
Well, that's the whole idea, is that we are able to offer an option for these patients that doesn't involve any donor site tissue, so the morbidity is very low. And most importantly, the operation itself to install it is going to be very quick. It requires minimal training to the head and neck surgeon who is involved in oral cancer treatment. And we're hoping it's going to revolutionise the way people get reconstructed, and not just partly reconstructed, but fully reconstructed, not just with the jaws, but with the teeth as well.
Clearly a massive leapfrog forward in this particular surgery. 3D printing is fabulous for the personalisation of device manufacture. That's great, but there's also the personalisation of the design process. And what I'm wondering about in terms of scaling this out and up, it took 3 years or so to go through the first, let's figure it out, and the second surgery was probably a whole lot quicker. But the effort in terms of the design work, where I'm guessing most of the work effort from here on in is, can you give us a bit of a flavour of how that is by patient and complexities around that, with a view to scaling it up to make it available everywhere, including the third world?
In my little company, I've only got 3 employees, or 3.5 at the moment, and one of them is just inundated with paperwork. I mean, the TGA requirements is just incredible, absolutely incredible. And the amount of paperwork we have to go through means that it's going to be months and months and months before we can get that jaw up and running, even though the patient's patiently waiting to have it. So it's, once we get through the paperwork, once we get through all the approvals, you know, it'd be nice to validate things, but validation takes a long, long time, and I'm not sure how long these patients want to wait. They want something now. And so hence the commercial arm of my company, and then we've got the University of Melbourne desperately trying to validate the thing. So instead of years, I'm trying to sort of compress it into months. So there's an enormous amount of work to go through just to get it approved so that we can start using it. The good news is that patients are keen. They are really keen, even though you say, look, we've never tried this before, and you'll be the first. And they'll say, look, I really don't care because I have no other options at all.
Yeah, and I think part of scaling up the process is about having the right tools to do it. And it took us 3 years to get to this point because we had to develop all the tools from scratch. So now we have capability to develop patient-specific musculoskeletal models. So we can now go ahead and scan a subject like Richard, and we can develop a computer model of his jaw like we could with other subjects. And we can more rapidly now tailor prostheses to the anatomy in the appropriate way. And as George mentioned, the testing and the validation is absolutely critical, and we're hopeful we're going to get some government funding, which will provide a platform for doing really cutting-edge, rigorous testing, not just with computer modelling, but with cadaveric simulation. So we have some tools at our disposal at the moment, but I think as we become more established, I think things will move more quickly.
I'd just like to add, when we build a model, we do a lot of validation. So in cases like this, it's cadaveric validation. In any opportunity for even live human subjects validation, we also do that with in vivo measurements technique. But I think one of the things that we never really quite we haven't been pushing hard enough is actually to use a virtual model or to use model to perform validation. I think computation model has actually, reached a stage where we are quite confident how to interpret these results. And we see it in the aircraft industry. I think one of the planes was actually virtually, designed. And then I think it flew off. Not sure I want to sit in it, but but the whole thing is I think we haven't yet explored in the biomechanical field because human is so complex. Whereas in the engineering field, using computation models to validate, a design has actually been quite mature now.
It seems like scaling from a technology standpoint is pretty much covered, but I can also see that there's a lot of the labor side of the process in terms of getting the expertise that really understands the anatomy as well as the technology that's involved in producing these models and subsequently these printed prostheses. Now, from that standpoint, how accessible is this from a cost standpoint to a typical patient across the globe?
I think with 3D printing, it's really speeded up the process of prototyping, and it has reduced the cost of going from paper, in other words, the computer, to the actual model in your hands. So as soon as I say, yes, I like that particular prosthesis, we send it off to the manufacturer and they'll have it printed overnight and sent to us within a few days so we can actually look at it. So 3D printing has revolutionised, speeded up the whole process of design to actual product. Now, what remains to be seen is whether going forward, particularly with stock devices, whether 3D printing is an appropriate medium for providing that prosthesis to the surgeon or whether we go back to milling them. But as you can see with the subperiosteal in particular, as well as the total jaw replacement, they need to be customised. And that's where 3D printing really comes to its own, that there really isn't any alternative or practical alternative to 3D printing, and that's where it's going to grow.
Yeah, I absolutely agree with that. I don't think we're going to be looking at a scenario where total knee replacements and total hip replacements are being rolled out using 3D printing technology. So those sorts of devices have been around for decades, and they've been refined, and there'll be around 40,000 hips going in to patients in Australia in 1 year. But the real benefits of 3D printing, as George just mentioned, are really to fabricate bespoke, sort of one-off devices that are tailored to an individual patient's anatomy and pathology. And yes, it does take time to do that, and it requires special expertise to do that. But you have to start somewhere, and OMX Solution and Melbourne Uni are working closely together to make that pipeline possible.
We might move on to the...
Hi. Great stories. I had a question on regulatory though, because at the moment you're making one-offs for patient X, the patients that you mentioned, for example. And you mentioned that you're drowning in paperwork for one patient. So when you're doing 100 patients or 1,000 patients, is the paperwork that you do for one the same as that you do for the second and third and the fourth, or is each individual item that you produce a one-off batch of X and you have to do the paperwork for that one, every single one that you make? Or do you see a path forward where the regulatory environment can change to assist in personalising these sort of implant devices?
What I see is the first few months are really the difficult stepping stones. Once we've got that initial regulation on hand and approved and we've got all the documentation, then I envisage that it'll be a more streamlined process. But because it's customised, you still have to provide some documentation for every patient, albeit not the pages and pages you need for the very first case. But there will, I hope, be a streamlined process where we can fulfil the needs of other surgeons who want to use this product from a customisation point of view. That's something we'll be continually talking to the TGA about, streamlining the whole process of the customised side of things. Not so much the joint. The TMJ, we have TGA approval now, so we're able to develop stock devices. The good news is that we still use the 3D technology to size them up for each individual patient. So the patient still gets scanned. We have a software program where we rapidly size up the actual joint to the patient and then send it out to the surgeon to implant it. So it's a hybrid between full customization and a full stock.
Yeah, I really like this story, this vision that George had, and he told me probably about 6 months ago that in the future a subject will be able to come in for a consultation, and after the consultation they'll be able to go downstairs, have their heads scanned, and the files from the scan will be sent to a room where there'll be some engineers who will then rapidly design and fabricate the part, and it'll be sent off to be sterilised and then couriered back to the rooms where the surgeon will place the component surgically within a period of around 2 weeks. So that would be the vision, and I think that's where we would like this to be in the future. And I think as the process becomes more streamlined, as George says, so we start developing like components, I think it will become streamlined. So for example, now if we come up with a slightly modified version of the TMJ prosthesis, we're not going to have to do near the paperwork than we did the first time.
I think just to add to regulatory, I think the regulatory challenge has to go beyond just the components. I think you have to look at the process now, because the process is quite unique now, that you have to create model of the patients, and then you have to use the model to plan your surgery, and then eventually the product that is then made is customized. I think that process has to be taken in a fairly holistic manner, rather than, oh, let's look at this product, do we give it a pass or a no? Yeah. I think the future is probably going to be like that.
Sorry, I've got a final question up the back.
Yes, can you say some more about how you intend to attach muscle to the metal prosthesis?
The very first 3D printed prosthesis was done in Belgium, and it was quite a thick, bulky prosthesis. Interestingly, it received worldwide coverage, but no one ever knew what happened to the patient because the patient didn't want to be interviewed. I can tell you right now, my guess it's failed. The reason it would have failed is because there was really nothing to anchor the muscles to. And so when I thought about developing a brand new jaw prosthesis, I wanted it to be as thin as possible, and I wanted it to be as perforated as possible. And the way we anchor the muscles and ligaments are through those perforations. So not only does it allow the blood supply to perforate through, to trickle through from the deep layers of the floor of mouth out to the skin, but we're also going to put non-dissolving stitches to try and bring up the floor of mouth to anchor it through those holes, so that there is something for soft tissues to attach to, as opposed to just simply having a smooth surface. So it's the holes in the actual prosthesis which are the anchoring areas for the soft tissue. Mind you, we haven't tried it yet, so it's all in my head.
Well, it sounds like an excellent idea, I have to say. I'm actually going to have to draw things to a close. So thank you everybody for attending. Thank you to our speakers for a wonderful story, a wonderful presentation, and to Luan for organising this evening. So thank you very much, everybody.